Absolutely. All right, well, good morning. Thank you for attending our talk instead of Sono Games. This is Mel and Kel with Firearm Injury Prevention from the Bedside.
All right. So we have no disclosures whatsoever. So objectives for this presentation, at the end of this, we hope that you'll be able to identify groups that are most at risk for firearm injury and death within the United States, demonstrate the different mechanisms for safe firearm storage, be able to identify opportunities for physicians to counsel patients at the bedside, and demonstrate the motivational interviewing techniques for that bedside counseling, and then be able to suggest some implementation strategies for bedside counseling and education in your emergency departments.
So for this, we are going to have sort of an interactive portion to our didactic using PolyV. So you can scan the QR code and it should pull up on your phone, and then you can put your name in or you can skip that part.
All right. Working? Good? No.
There's like so much of a glare, it takes my camera a minute to found it.
All right. So, what is the big deal with firearm injuries? So how many deaths do you think occur from firearms in the United States each year?
Free text.
Yeah.
What?
No.
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 Too many.
Accurate.
Sure. 40,000. We know how many people are in the room, so we know if you're responding. I think we can go on.
All right.
I know you got 2/3 participation.
We've actually got 50%. We have our ambassador as well.
Oh, that's true. That might just slow.
All right. So looking at firearm deaths per year in the United States, over the past decade and a half, it has been steadily increasing and actually has a jump even in the 2018-2019 timeframe. So this is from the CDC, and what it actually shows in 2016 is that firearm deaths has actually surpassed MBC deaths, and that trend is continuing even with preliminary data in 2021 and 2022. This one you can at least click a box. What is the lethality rate of suicide attempts involving firearms?
For men or women? It's different.
Not lethality.
Oh.
Men may use firearms more, but
Of all
Yeah,
users, no,
Yeah.
it's like of all users of firearms who
For
attempt
suicide.
suicide,
Yes.
how many are lethal?
So, yeah, so we're 0., yes, women use it less, but when they do, so equally successful.
exactly. All right. So when it comes to firearm injury and suicide, of all firearm deaths in the United States, 54% of them are due to suicide. Yet firearm use for suicides make up only 1% of suicide attempts. But 50% of suicide completions use firearms, and therefore that number, 85% lethality mortality rate when firearms are used in a suicide attempt. So while they make up a very small portion of suicide attempts, they are very, very lethal. And very
Problem as a method, it's a very effective method of completing suicide, which is the problem.
And then when it comes to the morbidity and mortality of firearm injuries, when you look at normal traumatic injuries, you tend to see this pyramid of ED visits to hospitalizations to death. So as you kind of get more severe, there's less of them. So think of the MVCs we see in the emergency department. The majority of them are usually fine. They come in, you get an x-ray, they might have a fracture and they go home. A couple of them get hospitalized and even less of them die. Whereas with firearms, it actually tends to be more of a tower. So you actually see the number of ED visits is fairly similar to the number of hospitalizations, which is fairly similar to the number of deaths. So that morbidity and mortality rate is pretty high with firearms.
So who is at risk of firearm injury?
What groups do we think are at risk?
So part of our focus for this talk, right, is practical intervention at the bedside in the emergency department.
And I believe you can submit multiple times if you have thoughts.
Multiple thoughts.
Well, it's supposed to be males.
Male. Okay, yeah. Children, homes with firearms, alcohol, gun owners. Perfect.
All right.
Which is a perfect segue. So anyone who comes in contact with a firearm or has the potential to do so is potentially at risk, right? But once again, we're focusing on practical bedside intervention. So we want to highlight a few populations, some of which you may consider already and some of which you may not have thought of. So anyone who's experiencing suicidal ideation should have at least the question asked, do you have access to firearms? Plus, do you have access to other lethal means, right? Patients with dementia who may unintentionally injure themselves with firearms in their home, those experiencing or who have experienced intimate partner violence, and those who have previously been injured by firearms. So we know trauma is a chronic disease, right? And so firearm injury is part of that. If you've been injured by firearms in the past, it increases your risk for firearm injury in the future. And then once again, we want to highlight that there are a lot of people who may come in contact with a firearm and not understand how to safely use, store, or disarm that firearm that could unintentionally injure themselves or other people. And so children are the classic example of that, of someone who may come in contact with a firearm and cause injury without intending to do so. So once again, as Melanie or Dr. Yates mentioned already, 54% of the firearm deaths in 2020 were suicide by intent. 43% were by homicide, and then 1% were unintentional, 1% were legal, which means some sort of interaction with police or the legal system, and then 1% was other. So once again, although there are a lot of feelings about firearm use and injury in the United States right now, we want to focus on practical interventions you can do at the bedside. That's why we're highlighting suicidal ideation and then unintentional firearm injury, because there's a great potential for impact when we have those patients with us in the ED. So what is considered safe storage? So one reason we want to focus on this is one of the key barriers to intervention in the emergency department is gun owners don't think healthcare professionals know anything about guns. So we want to teach you some kind of practical conversation starters so that you can actually talk to your gun-owning patients about what they're doing to store their weapons safely. So how do you safely store firearms? Safe. Love that.
Love that.
Unloaded.
Yep.
Separate. Kieran with ammo. Unloaded.
Locked.
Oh,
Yes.
yes. Yeah, no, that makes sense. That makes sense.
Just store it safer.
In a box, safety, locked. Okay, perfect. So options for safe storage are a gun safe. And you're going to see a key theme here. So gun safe, a locked ammunition box that is specific for weapon storage, a cable lock, which is a cable, like a bike lock essentially, but stronger, that will go through the trigger mechanism and also has a locking mechanism, and then a trigger lock, which physically covers the triggering mechanism and also has a separate locked component either by code or by key.
And you might be wondering too why we have these specific things when suicide is the #1 death of firearms, but there have been previous studies that have shown that actually having like a prolonged amount of time from thought of I want to harm myself to actual attempt, if you can prolong that amount of time, you can actually reduce the amount of completions or attempts that are occurring. And so not only are these beneficial for those unintentional injuries, it is also beneficial for the suicide attempts because people have more time to think.
So on that note, so weapons should be stored unloaded. They should be in some sort of locked container like we mentioned on the previous slide. They should be locked in a compartment that is separate from the ammunition, and once again, that is not loaded into the firearm, and then away from unintended users, specifically children or those who may have developmental delays, or like we said, patients suffering from dementia. However, really anyone other than the owner of the firearm should essentially be barred from accessing that firearm. So which of these is considered safe storage? And you should be able to just like click on the image whenever you have it on the Pull EV. Okay, I see a couple.
All right,
Perfect,
nailed
100%.
it.
So what's wrong with the top right? Everything, right? Everything. That's like a child with a loaded firearm. What's wrong with the top left? This one's the hardest one, I think.
Or
Ammo's in the gun safe, exactly. And then what's wrong with the bottom left?
He's not tall.
He's not tall enough. Right, exactly. So it is separated from ammunition, and it is sort of physically away, but it's not locked, and it is accessible by an unintended user of the firearm.
So the next portion of this, are ED physicians counseling patients appropriately, or just counseling them at all? So do you counsel ED patients about firearm injury prevention where you work?
This is a trend, right? And one of the key, like where I trained in Tennessee and where I work now in Ohio, outpatient pediatricians do this exceedingly well, right? They talk to every patient every time. Do you have weapons in the home? How do you store them, right? And I would certainly hope that outpatient pediatricians are seeing fewer victims of firearm injury than we in the emergency department are. So this is our lane, and we need to get in it. This is something that we should be doing with every patient, or at least patients who are at risk of firearm injury.
And then approximately how many patients with suicidal ideation specifically, so that complaint that we see often, have lethal means assessments in the emergency department? All right. So as you might imagine, we have many missed opportunities within our emergency departments across the country. And so this was one study that looked at a specific emergency department population and patients specifically with suicidal ideation. And they looked at if an ED physician, when they first assessed a patient, did a lethal means assessment, meaning did they find if they had guns in the home, how they were stored, those types of things. And then also looked at a research staff who was doing a specific screening on all of these patients with suicidal ideation. And the outcomes they looked at was, A, do these patients have firearms in the home, and was it documented in the ED chart? And what they found was that of the patients presenting with suicidal ideation, 11% had firearms at home, yet only 50% of patients that presented to the emergency department with suicidal ideation had a lethal means assessment by an ED provider. And so, and additionally, on top of all of that, those who had firearms at the home were more likely to consider this the method of choice if they had it access at home. So we are not doing a great job of screening patients for firearms who have suicidal ideation. And patients, so as we kind of talked about previously, patients don't find us very, knowledgeable on this topic. So patients are willing to discuss firearms and safety in the ED, but firearm owners themselves are less likely to follow advice about safe firearm storage and temporary firearm transfer because they don't believe that we are knowledgeable about this topic. So one of the things that we can do when it comes to counseling in the emergency department is make sure that we focus on well-being and safety, that we're knowledgeable on the topic, hence this talk, and have an understanding of the culture. So using things like, I want to prevent firearm injury, as opposed to saying gun violence, can make a huge difference in how patients will respond to your discussions. And then making sure it's really individualized. So you're not reading off a script on a paper, you are asking them questions based off of what they're talking to you about, and making this solely on well-being and safety can be very beneficial. So once you've identified those at-risk patients, majority of them are suicidal ideation, but we also have many others that are the recidivism with concern for repeat firearm injury in our emergency departments, unintentional. We have to make sure to ask them if they have a firearm still at home and how is it stored. And then you can ask those specific questions. Oh, it's stored in a gun safe. Is the ammunition somewhere else? Is there, and those can be those helpful questions that they say this person's knowledgeable and I can trust them with this discussion.
One thing for me too that I thought about from this is essentially like our demented patients, right? When we're thinking about safe disposition for like an older patient who we may be on the fence about whether or not they're safe in their home, I essentially never ask, are there firearms in the home and how are they stored? And so I think that's another sort of potential high impact area that we have in sort of safe disposition planning for folks who may have sort of some sort of inability to sort of like be safely around that firearm.
So then how do we implement this into our emergency medicine education, both with, physicians and other providers that are present within the emergency department or within our residency and medical school education?
So how can you implement this in your department? Or maybe how do you already implement this in your department? So we're all from similar departments. We at least have 2 departments represented,
Right.
I know. Ohio, how can Ohio lead the charge in firearm injury prevention?
Ask everyone.
Socially
Socially
M fellows, yes.
I think a big part of it's gonna be making this, and it sounds awful, but I think it's necessary for any sort of change, making this kind of considered standard of care and
Mhm.
effective, right? So like, I was telling Caroline, so my husband's a family medicine physician, and he literally had to go through all of his charts, all of their practices charts, and look at patients who were, I think it was 13 to like 27 or something, some age group that was defined by the American, like Academy of Family Physicians, and look to see if, and in the note for that month, did they mention gun violence, did they mention this like safety box? They had the safety box in the offices, so they could give out to patients, and then they had to, like, and there was a dot phrase, right? And just, like,
Right.
scan the chart, a little dot phrase, and then that was a metric that they had to report to ASP.
Yeah.
And, a whole bunch of clinics were on there, and they got 8 people one way or the other. So I think until it's like that, and for us, maybe the equivalent that you asked question, or,
Yeah.
next to our clothes to give patients and our bath products, that cabinet, right?
Right, yeah, exactly.
A super track cabinet or minor care cabinet, you have a couple safety boxes.
Yeah. Or even just like, oh, go to this
Cable
place and they will
lock
give
or-
you
yeah.
a cable lock or something like that.
Yeah.
Yeah.
So can I ask a question?
Yeah.
For real, you. I think one of the things that makes a lot of people uncomfortable, and I know this was a huge deal in Florida, right? Was like the legality, are you allowed to ask people and whatnot? And I know we're allowed to ask people, right? We can educate them, but like, what is that line? Like, if I have the elderly demented patient who's like, oh yeah, I got 6 shotguns and they're just under my bed, like, what, can I call Adult Protective Services? Can I call their family and express my concerns? Like, what are the legalities around, like, actually doing something other than just telling the patient that I think that's unsafe?
I think that's the majority of it, is being able to counsel them on safe storage. Like, have you considered using this for your storage method as opposed to just having it under your bed? Why are you concerned about that? If it's a dementia patient where you're trying to actively, get them home safely and you're having to talk to family anyways for whatever reason they presented to the emergency department, I think it's reasonable to talk to the family and say, look, your family member has this. Have you guys considered other safer methods of storage? Have you considered transferring those firearms because they are at risk for injury? You can do that, there's red flag laws in certain states for, firearms in a home, which patients often don't trust, police and any sort of law enforcement when it comes to their guns. So there are a lot of temporary transfer laws where essentially if you have someone who you're concerned about, you can, in most states, and there's multiple studies and like papers out there on this, where they can temporarily transfer while they have that suicidal ideation, or at risk.
Specifically for Ohio.
So for Ohio, you're allowed to any family member. I mean, we just got rid of our concealed carry laws, so I think anyone can really have a handgun specifically. So there's not really much laws on that, so they can temporary transfer for as long as they want. Additionally, in Ohio, there's definitely gun ranges will sometimes take them. If they have like safe storage, law enforcement can obviously take them, and some gun stores will actually have it as well. So there's multiple places that people can take them if they don't have family members as well.
It's almost like a safety deposit.
Yeah.
I think too, this is just from my personal experience growing up in the woods in West Virginia. Like, I think you can engage local, Yeah, right. No, absolutely not. Because like the gun culture is such that like if you would unsafely store a firearm, that's like pretty taboo. Like I think you can engage, and that's what the plug for engaging local resources that are centered around like firearm safety. Like there was classes in the school, in my school on the weekends, like classes in the community, and like I think like it is a barrier that is surmountable for firearm owners to think physicians or healthcare providers don't know anything, because a lot of firearm owners are willing to have those discussions and are strong proponents of safe storage and preventing unintentional injury and then access to weapons in suicidal patients. And so I think there are community resources that you can work with if you're willing to like have those honest sort of barrier bridging conversations and direct people to.
I mean, if you talk to any gun owners, like gun shows have safety classes, they have, safe storage like available that they'll give away for free. So it's available in the majority of the gun community. I think there's that barrier. Sometimes there is such a wall.
There's
So-
this like an absolute distrust of like I own a firearm versus I don't think you should. It just immediately becomes this barrier. And that's sort of one of the goals of our talk, is to help us be comfortable as physicians having conversations about something that we may not personally feel comfortable like owning or know much about.
So breaking through the barriers. So this was actually a large consortium of, I think it was healthcare providers, so it was nurses, physicians, that type of thing, that was majority looking at firearm suicide prevention. So they were talking about a lot of the ways that we can counsel, like teach providers at the bedside to counsel. And then on top of that, there was additionally a study that looked at implementation for like resident physicians, and they were not just emergency physicians, it was OB-GYN, it was surgery, it was like primary care, so internal medicine and family medicine. But it was all of those physicians combined doing a required didactic and case-based series, like two-part, and really showed that, one, prior to the implementation of this, the majority of residents had no idea about anything on guns, and that just having a two-part series on this allowed them to feel much more comfortable to talk to their patients.
So from this study came sort of their preferred mechanism of transferring this information, which was didactics, modules, simulations, and then kind of dedicated electives, which Dr. Yates has done a dedicated elective, which was very effective.
And a lot of the simulations too are those discussions that you have, like those case-based ones. So the patient comes in with suicidal ideation, you need to hit the checkbox that you've talked to them about a lethal means assessment and go through that. And these are some of the probably best resources for initial startup of this. The clinicians in firearms, this was with Stanford. It's their safe around firearm prevention, or firearm injury prevention. That is like a 4-part module that is incredible and does not take too much time to go through, and just gives both the temporary transfer stuff to basics on different types of firearms, their safety storage mechanisms. And then the Bullet Points Project, bulletpointsproject.org has incredible cases and modules and, brochures on safe storage that I think are super beneficial for people who are trying to start this up and learn about this. And eventually I hope it gets more involved in both medical student and resident education, because it's needed.
We actually are a little bit over time, but we were able to take some questions, and you guys know where to find us. And there's our references if you're interested. So thank you.